See, so now she's laying on the table, and you draw a line down. It's really not, you know, some people have I call them a banana face. You know where the whole face is curved like that? Huh? Yeah, and Taylor doesn't. I mean, it's a pretty straight line down this way. So this difference is not because the jaw's off to one side.
Okay, that would help you.
Yeah. So when you get this line, you look pretty good. So and so now I'm looking. If she's looking straight up at the ceiling, her two eyes seem pretty level, but this one might be up a little bit. But again, the visual stuff is just clues. What's most important is what you feel.
Okay.
So. So again, ideally, by the time you do this work on the person in the office, you've already like freed up the thoracic outlet or any diaphragms, that kind of stuff that need to be done. Okay. So again, the first vault hold is I usually put my little fingers right on the table and go in right where the where the muscles come down and where the head touches the table, and that way I know I'm on where the occiput comes down and turns this way. I want to be at least down on the part that's going straight up. Okay, and the reason for that is when the occiput goes into flexion, that part's moving down, right? So you're going to get this kind of a motion, but the vertical part of the occiput is going to be moving this way, and so you get a feeling like it's going this way instead of that way, and it can confuse you. And especially not with these 4 lesion patterns, but with the next 3 lesion patterns we talk about, it can confuse you. So you want to, so I get my little fingers clear down here, and then I find that sweet spot right in there. So she's already in treatment, she's already wobbling around. So this is one, if you want to, you can have a person scoot down so you can rest your whole forearms on the table. Sometimes that's helpful. But I can rest my wrists on the table, so that's pretty good. But there's already heat coming out of the greater wings, especially on that left side. It's just so I'm just following the wobble right now, since she already started into treatment. So when they're in that therapeutic pulse, you can't really assess flexion extension very well to know if she's got that kind of lesion. But I can so checking the flexion extension lesion in the sphenobasal joint is just like checking it if you're at their feet or at their pelvis or any other place. You know, just like it goes into a flexion lesion would be flexion, 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 extension, flexion, 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 extension, you know. And I don't sense that she's doing that. So then the next one we're looking for is a side bend. And what I would feel if she had a side bend is it would feel like one set of thumb and fingers were close together and the other set were further apart. So I would, if she had a left side bend, it would feel kind of like that. Okay? And if she had a right side bend, it would feel kind of like that. Because you can imagine that sphenobasal joint side bending. Okay? So it's named just for what it does, so it's easy to remember that. So then, if she had a torsion, what I would feel is my one thumb would feel like it's higher than the other thumb. Okay? And the other way to tell is if you put little test motions in, you can test torsion with little test motions. It'll be easier to go that way than to go that way. Like say, if she's got this, like a right torsion, or if it's a left torsion, it'll go easier this way than that way. So let me just see what we get when we put little test motions in for torsion. So side bending, it feels like I put little test motions in, it feels pretty even on both sides. So torsion, yeah, if I try to induce a right torsion, I just get resistance and starts to wobble. If I try to induce a left torsion, I get the sense like it's just going and going. So again, that would be more of a left torsion. But her torsion is very, very minimal. That's why it's hard to tell which eye is really higher than the other one, because it's very minimal. It's not. Okay, so then to check for lateral strain, I would put in little test motions this way. Or again, you can tell by just feeling. Interesting. Now when you just look at Taylor when she's laying on the table, so when she's standing up, we could really see that shift, right? Mm-hmm. But now look at this area when she's laying on the table. Come behind me and look at that. I guess it's still a little steeper here, isn't it? It felt like that. But it's not near as noticeable as when she's... But this angle here is a little more sloped than this here. Okay. It's just not quite exact. It's just about like that. So what I would do is come on here and put the little test motions in, and again, to treat this, I would use indirect treatment, and I would encourage the sphenoid laterally. And when I do that, it starts to wobble and start to. So I'm not going to treat it. We'll save it for who works with you. So we've only gone through the first 4 lesions, and if anybody has a more serious restriction, you should be able to diagnose it, because it won't fit what we just talked about, and they'll still feel stuck. And just call me over and we'll look at it. But how you, like, she's got 2 different restrictions, right? She's got a little bit of a torsion and a little bit of lateral strain. So how would you treat that?
Follow the body?
That's a good way. And usually what it will tell you to do is stack the lesions.
Oh, okay, so you get this one here to its end point, and then you start with the other one.
Exactly. You hold it where it is. So, and you stack them in order of this chart.
Okay.
That's why it's important to remember the chart. And that's why I say, you know, a couple of them are pretty equivalent. So with side bending and torsion, it doesn't really matter which one you do first. You can do the side bend and then bring in the torsion, or you can do the torsion and bring in the side bend.
So you do the less severe first?
Yeah. So if she had, say she had a flexion lesion, and say she had 3, so she had a flexion lesion, a torsion, and a strain, I would encourage her into flexion. While she was in flexion, I would put the torsion into it, and then while she was in the torsion, I would do the laterals. I would encourage it to the left side. And then just hold it there and let it wobble and unwind and that kind of thing. Okay? So that's called stacking lesions, and we'll talk about that again more tomorrow.
Can you do it like in the air?
Okay.
How it...
So what I would, if she had those 3 lesions, what I would do is I would encourage it into flexion, okay? And then I would put in the torsion, and then I would put in the side bend, and then I'd hold it there, and then it starts to wobble and yeah. So it's essentially like lining up the tumblers on a combination lock.
Okay.
One of those chain locks.
So is that compression, that technique that you're doing, not really compression, but you're doing it in the direction of ease?
Those are all, that's indirect.
Yes, all
So
the
you're
That'd be all
like making the lesion more obvious, more
Yeah, if it sticks out, push it out
And then just
further.
holding it and then going on to the next.
Yeah, and
That's called stacking.
hmm and it's really more, I mean, how much force was I using?
Not much.
It's really mostly the intention too, you know? So you're taking into that lesion, just intending to hold it there, put in the other lesion pattern, intend to hold it there, put in the other lesion pattern. Now it's not uncommon people have more than one lesion, so you'll get pretty second nature at stacking. It'll happen pretty fast. But you'll get better clinical results, I think, if you do it in the order of that chart. Like I do, I wouldn't want to put in the torsion and then try to do the flexion.
And first you have to diagnose all three.
Right. And so you diagnose them by either by just feeling it and seeing what it's doing, but then if you wonder, you can always put in the little test motions to test it in the different directions. Okay, just like we do when we start unwinding a joint. Okay, is it going to move easier this way or that way or that way? And you just put in the little test motions and see how it responds. And the test motions how strong are those?
Yeah, I could barely feel them.
Yeah.
Just barely little tiny.
Yeah, so again, it's mostly intention. I say 90% intention and 10% motion. So if I wanted to test her torsion, so I'm testing it, pushing it to the left, and it goes real easily. And now I'm testing it, pushing it to the right, and I just go, and it stops, won't go. So I can exaggerate it, so you can feel it. See how that won't move?
Mhm.
Feel that?
Mm.
See the difference? See, I try to go like that, and it's just like hitting the brick wall.
Yeah.
I go like that.
Oh.
So that's greatly exaggerated.
Yeah, you
I don't
wanna
need
do
that much force to feel it.
Wow.
So you're stepping it in that direction